Thank you again, doctor. Let's give him another round of applause. You know, it's clear that many of us don't sufficiently understand addiction or what is the appropriate support to give addicts. Dr. Carl Christensen will teach us how to identify, understand addiction to prescription drugs and heroin, and how medication-assisted treatment is helping. Dr. Christensen is a clinical associate professor in the Department of OBGYN and Psychiatry at Wayne State School of Medicine, dealing with methadone and outpatient substance abuse treatment. He is also medical director of the Michigan Health Professional Recovery Program, which mentors doctors, nurses, pharmacists, and caregivers of addicts. He owns Christensen's Recovery Service in Ann Arbor, a pain med detoxification and addiction treatment center. Please take notes, because you're going to get some really good information. Dr. Christensen.
Thank you, sir. Do I run it up here? So how do I see the presentation up here? Can I? Nope. All right. So is there any way to see the presentation up here? Is there any way to see the presentation on the screen? I'm just looking at myself. All right, so I'll stand out here. Let's see here. So just my disclaimers, I work with methadone therapy at Wayne State. I'm a buprenorphine provider. I work with the Michigan Health Professional Recovery Program for impaired physicians. I work at a abstinence-based 12-step treatment center out in Ypsilanti. And I work with law enforcement at identifying doctors with overactive prescription pads, and you probably know a few. And I work, I've pretty much done all types of treatment, including Vivitrol and detox. So I like to consider myself broad-minded. The word promiscuous has also been used, so I'll let you decide which one. So we'll just jump right into this because we're probably not going to have enough time. But, okay. Nothing's working up here. All right, so the first thing is you as an addiction provider probably hear a lot of nonsense about addiction is not a disease, it's a phase of life, and you need how to learn how to deal with this. Just like when you go out in the backyard and you have a lot of mosquitoes around you, you need how to learn, how to learn with that also. This is the Donald Trump of addiction medicine. This is Stanton Peele. He's a lawyer and a PhD, and if you buy his books, he will show you how addiction is not a disease, but actually simply a stage of life, and he will teach you how to learn how to grow up and avoid the disease model of addiction. And this is also another book that he was involved in, and he will point out that the majority of people who have a problem with alcohol and drugs are not addicts, they get better on their own, that's true, and that the disease addiction model is a false model. So I want to give you a different kind of scenario. I'm a former GYN cancer surgeon. I used to deal with patients that had ovarian cancer, and these are two tumors from two different women who showed up with the same symptoms of ovarian cancer. The one on the left had a tumor, and the one on the right had a tumor that was the same size. The one on the left had no family history of cancer. The one on the right had a family history of breast and ovarian cancer. And the one on the left had no genetic predisposition to cancer, and the one on the right had the BRCA cancer gene. I can tell you that the woman on the left had less than a 1% chance of having cancer, and the woman on the right statistically has already died. And this is the same problem that we have with addiction. We have people who have the symptoms of addiction, but they get better on their own. These are abusers. And Mark Minestrina, who was in the same graduating class as I was, but I was never as bad as he was. He had a phrase, I actually had it in the slide, but I lost it. Addiction is a disease and abuse is a behavior. And that's true. And unfortunately, our new DSM criteria have merged these into two single diseases, which they really are not. Also, if you look at the history of heroin in Vietnam, about 15% of soldiers were addicted when they finished their tour in Vietnam. They were forced to detox, and the claim is that only 15% of those relapsed when they came home, so there is no addiction in Vietnam. That's complete and utter nonsense. By the way, 15% is about the percentage of people in the US who have underlying addiction. And these are all arguments that are used against the disease of addiction. So the next thing is you have to ask yourself what addiction is. It may be physiologic, which means you just need to get over the withdrawal. It may be a lack of willpower. It may be a moral condition, you're a bad person, and it may be an actual brain disease. So let's look at each one of these. So first off, physiologic tolerance and withdrawal means that tolerance means you have to take more and more of the drug to get the same effect. So if I'm taking Xanax to deal with my little problems of life, I'll wind up needing 2 a night, 3 a night, or 4 a night. Withdrawal means that the opposite effect of the drug occurs when it's removed. So when I stop my Xanax or I run out because I take it all, then I'm going to find that I have the opposite effect. I'm going to get shaky, upset, and I may even have a seizure. And neither one of these have anything to do with the disease of addiction. Next slide. So I can take everybody here in the room, maybe not this room, but normally everybody in a room, and force feed you morphine for 2 weeks and then suddenly stop. And everybody will go into withdrawal. You'll get sick, you'll get cramps, diarrhea, nausea, and you'll be sick for about 3 to 4 days. And about 85% of you, again, maybe not this crowd, but 85% will go on with normal lives. About 15% of us will start robbing party stores because we've activated the disease of addiction. And just to show you, this is a rat brain, but this is the withdrawal center in your brain. It's way back in your brain. It's called the locus coeruleus, and everybody who stops a medication after about 2 weeks will experience withdrawal. But the next slide shows the addiction center, which is the nucleus accumbens that responds to the pleasure or addiction drug, which is dopamine. We'll show more on this later. So the next argument is that addiction is a lack of willpower. And I've taken 4 gentlemen here who are alleged to be alcoholics and addicts. I've tried to mix up the Republicans and Democrats. The 2 on the left were alleged to be amphetamine addicts. The 2 on the right were alleged to be alcoholics. And you can say what you want about any of these gentlemen, but no one has ever accused any of these guys of having a lack of willpower. And history is full of strong-willed addicts. It simply does not add up. So you can talk about being immoral. Everyone recognizes the guy on the right. That's Freud. You can recognize him by the cigar. The guy on the left is William Halsted. William Halsted is considered to be the greatest teacher of cancer surgery that ever lived. And it's not advertised, but he was a hopeless cocaine addict. He not only got himself addicted, he got his fellows, his residents, his colleagues using it, and you can only imagine what rounds were like with him in the morning. But if you actually go on YouTube and Google these 2 names, there'll be a video that pops up from PBS about how cocaine took both these doctors down. They weren't immoral, they were addicts. So we're left with talking about a brain disease, okay? And next slide. This is, again, a rat brain, and the cortex, the most advanced part, is on your right, and we're looking at the primitive forebrain, and this is the nucleus accumbens, which is the pleasure center of your brain. It responds to dopamine. When you walk outside and see all that pastry, you get a surge of dopamine and it makes you crave it. When you eat that pastry, you get another surge of dopamine and you enjoy it. Notice I'm not talking about a drug or alcohol, I'm talking about food. These things all apply the same way. Next slide. The gas tank for dopamine comes from an area behind it called the ventral tegmental area, and the drugs of abuse that we talk about either work directly or indirectly on the pleasure center through dopamine. Now the next slide shows, this is a small brain, it's a rat brain, but the frontal cortex, or what's called the prefrontal cortex, is what is you. That's your decision making, your higher thinking, that's what you are. And that is supposed to inhibit your pleasure center. So those of you who stop at the bar on the way home and stop at 2 drinks so you don't get a drunk driving ticket, that's your frontal cortex inhibiting your pleasure center. I'm going to show you how in addiction these different parts of the brain are all broken. Next slide. So this is work done by Nora Volkov, who is the medical director of the National Institute of Drug Abuse. And what you're doing is you're looking down in the brain from above. The brain is symmetrical, so you have 2 pleasure centers. And if you look on the left, you see 3 normal control patients. And the red you see is normal levels of dopamine. Those patients have normal levels and they are happy and content. On the right, we have a cocaine addict, next slide, an alcoholic, and a heroin addict. And you can see that in all those pictures, there is decreased dopamine. And one theory of addiction is that addicts, for different reasons, have lower levels of dopamine, so they turn to abnormal activities to build that dopamine up. And eventually, they wind up using more and more and getting less and less, and that is what the disease of addiction is. Next slide. So you can talk about one problem with this theory, and believe me, you'll hear it. They'll say that all these studies are looking at is brain damage. You use drugs, you burn out your brain. No big deal. So this has nothing to do with the disease of addiction. This is all made up. So this is a study done out in California where they took volunteers who were not using drugs. I don't know how they did it in California, but they did. They had negative drug screens, and they injected them with methylphenidate, Ritalin, which is pretty much like one of your patients injecting methamphetamine. Now, most of us, again, I can't apply it to here, but most of us would not enjoy that experience. You'd find it horrible. And what they did was brain scans on the people who enjoyed it and didn't enjoy it. The top picture shows someone who did not enjoy being injected with Ritalin, which is a normal response. Look at their level of dopamine. It's normal. Next slide. The bottom picture shows someone who liked being shot up with Ritalin, probably started doing it after the experiment, and look at their level of dopamine. It was decreased and they hadn't even started using. So this kind of blows the argument about dopamine studies just looking at brain damage. People who have an abnormal reaction to drugs may be walking around with low levels of dopamine for whatever reason, genetic or stress or trauma. So addiction is an abnormal response to a reward. Okay, next slide. This is a complicated study, but it showed that women who were overweight compared to normal women had abnormal dopamine receptors in their brain. The receptors didn't work right. They had fewer dopamine receptors, and here's the weird part. They enjoyed milkshakes less than normal controls. We always think that someone who is overweight enjoys food more. You may actually be enjoying food less and using more of it to get the same response. Okay. And if you go to an open talk of AA or NA, and I urge anybody here in the room who's involved with addiction who is not an addict themselves to go to an open talk. If you go to NA, bring a pillow because they tend to ramble on. But you'll always hear this statement. You'll hear somebody say, I didn't feel right. I felt abnormal. I didn't belong in my own skin. And what they're referring to is what we call decreased hedonic tone. Next slide. And I show this slide to my students and residents, and I say, pick out the addict in this picture. And everybody always focuses on the kids down in the front. Those are normal, happy little criminals in the future, okay? They probably wound up buying a pharmaceutical company and testifying in front of Congress, but those are not addicts. Now, if you look at, next slide, you look at the girl in the back, and this is obviously all contrived. This is set out by Jim Ballmer from Don Farm. If you say this girl is dysphoric because she has low dopamine, She may learn that she can use a drug or a behavior and join her friends in the front for a while. And eventually, the behavior will become less and less rewarding, and now you're stuck in the old gerbil cage. Now, the next thing to talk about is relapse and how it deals with addiction. And obviously, almost every addict at some point stops. You're either going to treatment, or you run out of money, or you get incarcerated. The problem is that once you get back out, everybody relapses, or almost everybody relapses, sometimes after a very, very prolonged period of time. Why does that happen? Next slide. So, again, next slide. This is a picture now of brain metabolism. Your brain uses glucose, and the red is glucose metabolism. And you are pointing upwards. That's your frontal cortex pointing up. On the left, we have a happy, healthy, controlled who is using up a lot of glucose and their brain is working. On the right, we have an active cocaine addict, and look at the amount of glucose metabolism you see. You don't. Now, that's no big surprise if you work with active addicts. You don't see a whole lot of higher executive functioning going on. But there's more bad news here. Next slide. On the top, we have the same control subjects, and the yellow and red you see is normal, and the frontal cortex is pointing up. And then in the middle, we have 10 cocaine addicts who stopped using 10 days ago. Look at the frontal cortex. There is nothing going on there. It is blank. It is dead. And you may say, well, so what? That's just 10 days. Everybody here in the room knows that's how much treatment you're going to get from your insurance company, if you're lucky. Or you may get 6.9 days, like Dr. Ministrini was saying. And we always are surprised when they use in the parking lot. Why? Because their brains are broken. There is no one is home. No one is running the show. Now look at the lower line. Next slide. These are folks who have gotten their 90-day chip. And if you were in our impaired doctors program, this is right around when we would let you go back to doing surgery. Anybody here having surgery next week? Okay. But you can see that there is a horribly decreased amount of brain metabolism going on compared to the controls, and we should not be surprised when this person relapses. Next slide. And basically, if you look at just go through the slides, top, middle, bottom, it takes about 1.5 years to recover from drug use, what you are going to get back, okay? And this is how I lose a lot of patients. I'll say, well, you've been clean for 1.5 years, so you've gotten back from your brain damage. But you were never normal in the first place, and people don't like to hear that, so sometimes they get up and walk out. But this is true. You will get back to where you were in about 1.5 years or 2 years or so. Next. So the next thing is, how do we make the diagnosis of addiction? And I'm going to use the DSM-4 criteria because I think they are more accurate and they differentiate abuse from dependence. Next slide. So going through these slides, tolerance, withdrawal, take more than you planned, can't cut down, you spend all your time getting it, using it, or coming over it, you give everything else up, and you use despite a physical or psychiatric problem. That's 7 criteria. If you have 3, we would say that you had dependence. Next slide. But there's a more accurate way of doing this, using the 4 C's or the 5 C's. When I don't have it, I crave it. All I'm thinking about is, and I was actually banned from here for a while, I think. There's a bar over on the 2nd floor. All I'm thinking about is when I get out of here, I can go over to that bar. I have to use it to feel normal. That's compulsion. When I start, I lose control. The person who wrote that commercial, Bet You Can't Eat Just One, they understood addiction very, very well. And I use despite consequences, despite loss of my family, my home, my job, my health, I can't stop using. And it's chronic. You know that you don't make a diagnosis of alcohol dependence or even abuse based on one drunk driving arrest. It has to be a repeated problem. Now, these 2 gentlemen are obvious. The one on the left is injecting heroin. The one on the right, it says, need cash for alcohol research. These gentlemen's lives have been turned upside down by their addiction. Next. And this will upset some people in the room, but if you smoke, you have 7 of the 7 and 5 of the 5 criteria. And again, the most common cause of death in recovering addicts and alcoholics is related to tobacco. And also, you can have a behavioral problem, okay? Up top left is somebody spending too much time on the computer. Top right is somebody spending too much time across the street at the casino. And the bottom is, I never saw this show, but apparently this was a gentleman who was on the reality show, lost an incredible amount of weight, and wound up getting married. But they all have active addictions in these slides. And the first time I heard this at an AA meeting, I'm cross-addicted, I thought it was some kind of complaint about religion. But people at the meetings know what we still fight about, that if you get in recovery from one drug and you're not really in recovery, you can just flip over to another one. Next. So recovering alcoholics will often gain weight, smoke, gamble, become sexual addicts, internet addicts. Next. And my most common consult at the Detroit Medical Center, besides pregnant patients, is the bariatric surgery ward. Bariatric patients may become alcoholics, opiate dependents, benzodiazepine dependents, and since you haven't treated their addiction, you've just blocked it, they can learn how to gain that weight back. And of course, someone found out that this was a myth. They said that people who go into recovery only have a 15% addiction transfer every year, so it doesn't really happen. But they should sit down and look at themselves, because normal people only have about a 1% incidence of addiction per year, and the recovering addict will flip over to something else 15 times more often. That's addiction transfer. It does happen. So, next slide. You're worried about your best friend. She has a history of heavy drinking, and she's been diagnosed with high blood pressure and high cholesterol. You advise her to quit. You went to a lecture on addiction, you paid a lot of money, and you heard an expert say that it's a disease, and you know that she can't stop. To your surprise, she stops cold turkey without any treatment and never drinks again. And you vow not to waste any more money going to hear experts at lectures, okay? So how did she do this? This is abuse. This is a behavior. This is not addiction. And the problem is that it can be very difficult to see which is which. And the best way for me to talk to somebody and say, do you really have a pain problem, or are you addicted to your pills? And that's very difficult to tease out, is I'll ask them, do your pills talk to you? And their eyes will get wide. And then I know that we're not dealing with somebody with a slip disc, we're dealing with someone with an addiction. And you have to tease those out. So just go through these quick. So these are the criteria for abuse. They got rolled into the DSM-5, and they took out the recurrent legal problems, and they added craving, which I thought was a very good thing to add craving. But these are different things than dependence. Okay, next. And again, the majority of people you see with alcohol and drug problems are not addicts, and if you read William White, he will talk about this, and using the 4 C's will help you to differentiate them, and unfortunately the DSM-5 refuses to recognize this difference. Okay. Now, we're going to talk about treatment. Just roll through these. The top ones on red are the behavioral treatments. We're going to talk about some of these, including abstinence, but we're going to focus on medication-assisted therapy. Next. The 2 different types of medications we're going to talk about are either agonists or antagonists. Agonists do the same thing as the drug you're trying to stop, and that's going to be either methadone or buprenorphine. The antagonists, the only one we're going to talk about is naltrexone, which is available either in tablet form or injection form. Next. This is an article from JAMA in 1965, the first paper by Creek et al., and they talked about the success rate they had with heroin addicts using methadone. In 1969, Dr. James Wardell, who trained me in addiction medicine, was one of the first people in the country to use methadone for pregnant addicts. And he established the Eleanor Hutzel Recovery Center, and that was a comprehensive treatment center using methadone. Next. Now, there are a lot of benefits of methadone. There's a decrease in death, decrease in IV drug use, decrease in crime, decrease in HIV and hepatitis C, decrease in relapse to IV drug use as long as you take it, And the problem is that methadone clinics have a horrible reputation, sometimes deserved, and the idea here is that methadone clinics are not places of recovery, but it's difficult for us to argue. These studies have been published over and over again. Methadone is very effective at treating opiate addiction. Next slide. You have to be very careful giving methadone. There are 5,000 methadone deaths a year in the US, mostly from pills. The problem is that methadone builds up in your body over a period of about 10 days. This is the same dose of methadone given 3 days in a row. Look at how the methadone level is climbing in your blood even though you haven't increased the dose. So if I give somebody the dose of methadone they need on day 1, I may kill them on day 7. So that's why we have to do it very carefully in a clinical setting. This is the study from 6 methadone clinics in New York City, Dr. Ball, and what he showed was over a period of about 5 years, next slide, there was a 70% decrease in IV drug use. A 70% success rate is huge in any type of medicine. In addiction medicine, it's just amazing, okay? Now remember those brain pictures. These addicts thought that since they had stopped using, they didn't need the methadone anymore. Next slide. So at the time they left the methadone clinic, almost all of them were abstinent, but within 1 year, next slide, 80% had relapsed, okay? Methadone works when you take it. It doesn't work when you stop taking it. Just like Prozac, just like my blood pressure pill, just like my sugar pill. Next slide. Methadone pills are responsible for almost all the methadone deaths. There are less than 1,000 deaths on methadone clinics in the country every year, and considering the severity of illness these clients have, that's a pretty good number. These almost always happens according to people who are abusing them. Next slide. So the next medication is buprenorphine. Buprenorphine is generically called Suboxone, Subutex, Zubsolv, Bunavail, or just buprenorphine. It is what we call a partial opiate agonist. I'll show you a slide. It doesn't give as much withdrawal relief, pain relief, or respiratory depression. Remember, addiction, opiates kill you by making you stop breathing. For that reason, it's much safer than methadone, and there are many fewer Suboxone deaths a year than there are from methadone deaths. And it treats both pain and dependency depending upon which brand you use. This is a slide, if you go to an addiction course, you will always see this slide. And what this is showing you is, when they go to your brain, what do these drugs do? Methadone, for example, does the most. It's on top. It gives you the most pain relief, withdrawal relief, and it makes you stop breathing first. At the bottom, you have naltrexone, which is the blocker. It gives you no pain relief, no withdrawal relief, and you never stop breathing. In fact, it's used to make you start breathing. We'll come back to that. In the middle, you have buprenorphine, which is between the two, and for that reason, it's called a partial agonist. It does not relieve as much withdrawal, but it does not cause the same danger. Next slide. And these are the brand names. And I forgot to mention I'm a speaker for one of the companies that makes buprenorphine. It's on the list here. But you have Subutex, Suboxone, Bunavail, Zubsolv, and generic buprenorphine. Those are all sublingual, meaning under the tongue, versions that are approved to treat dependence, not pain. On the right, you have a buprenorphine injection, Buprenex, a buprenorphine patch, which is for pain, and a new film that goes inside your cheek that is for treating chronic pain. It's just been released. And the FDA is clear that the ones on the left are for addiction, the ones on the right are for pain. And the addition of naloxone, which happens in Suboxone, Bunavail, and Zubsolv, is to deter you from injecting or misusing the drug. When you use it as directed, you do absorb a small amount of naloxone, which is Narcan, but when you inject it or snort it or anything else, then you get a lot more, and it will put you in withdrawal for a short time. Next slide. This is just one of the multiple studies on using buprenorphine for addiction. It works. This study shows that at the 2-year mark, which is the vertical line, about half the patients who enrolled are still clean. Now, it may not sound like much, but I'm going to show you later on how that's a big deal. And next slide. And the ones who stayed in treatment at 2 years, 90% weren't using opioids, 95% weren't using cocaine, and 85% were satisfied. This is an effective drug for treatment of opioid dependence. Next slide. Now, I'm an OBGYN, and that's actually how I got involved in this. I started working with Dr. Wardell back in 2000, and we have a lot of patients in Detroit who are opioid addicts. So what do you do when they're pregnant? Next. According to the government, SAMHSA, this is the old treatment improvement protocol, methadone is the gold standard up until recently. And only if you can't get methadone or the patient refuses it will we offer buprenorphine. And next slide. Then the mother study came along. This was a study done in like 6 places in the US and Europe, and there were some really nice places like Vermont and Austria, and I was the OBGYN for the Detroit site, and I got really excited, and I thought I was gonna get to Austria, and they said, no, you just stay right here, okay? And Dr. Susan Stein was the principal investigator for the Detroit site. Next. And I'm not gonna go through each one of these in detail, but if you look on the right, everything except the bottom line favored buprenorphine. The babies needed less medication, fewer days in the hospital, fewer needed treatment, they were bigger babies, less preterm delivery, and fewer positive drug screens. Everything screamed to use buprenorphine, okay? And the problem is that 1/3 of them dropped out, and the reason this happened was that we were transferring moms from methadone to buprenorphine, and we know now that that's really not feasible. Next. Okay. We have a huge opioid epidemic. You just heard this earlier this morning. So what can we do about it otherwise? Next. There are 2 blockers. There's naltrexone and naloxone. Naltrexone is a long-acting, slow-onset blocker. Naloxone is a short-acting, quick-onset blocker. And naltrexone is used for prevention of overdose, and naloxone is used for the treatment of overdose. Next. And naloxone will not reverse anything besides opioids, but even if somebody is using more than one drug, which is very, very common, usually benzos or alcohol, it may relieve enough of the withdrawal in order for EMS to get there and get the patient to the hospital. So even if they're using more than one drug, it still can be effective. Next. It comes in many different versions. You can get an injection. On the top right is something called Esvio, which it talks to you. You pull the cap off, it says, you know, stick this in your thigh or someone else's thigh and hold it down for 5 seconds. It counts down and then you're done. It's very safe even though it has a needle. In the lower left is a nasal spray, and there's a commercial nasal spray that just came out, so you don't have to worry about a needle. You just put it in the patient's nose and you spray either half in each nostril or the whole thing in each nostril. And on the bottom right is Olive, our pet therapy dog. So who is at greatest risk from overdose? People who are abstinent for more than a couple weeks are no longer tolerant, and they may overdose. People who are stopping their medication, people who are mixing opioids and sedatives, and we all know on the bottom line that heroin in Detroit is often contaminated with fentanyl, and that's the reason for the increased deaths. It's not the heroin, it's the fentanyl mixed in. Okay, next is going to be injectable naltrexone, which is called Vivitrol. There is a pill version available, which is Revia, but the problem is that if you're taking a pill every day and you decide you want to use, what are you going to do? Stop taking the pill. So it's not really effective. So the injectable form is given every 28 days. The only hard part is that you have to be abstinent from opioids for about a week or longer, so your client has to get a week of abstinence in. And sometimes that means going to a detox unit. It's not a controlled drug, so it may be more attractive to drug courts, and it has rare side effects. They can be serious like any other medication, but the most common one that I've seen is we had one client who developed severe depression and we had to stop the medication. This is a study comparing Vivitrol to a placebo shot. This was done in Eastern Europe, where being an addict is a very, very poor prognosis lifestyle. And you can see that at 24, out to 24 weeks, you had a big improvement over the placebo group. Next. I want you to look at this slide. This looks at craving. We always thought that if you got a blocker, you would just be miserable all the time and just crave, crave, crave. It turns out that Vivitrol cuts your craving in half. And that's a big improvement. Because if you ask somebody who has a year clean from drugs and alcohol, what did you think about for the last year? They will say, drugs and alcohol, okay? They crave it. They wish they could be back there. This cuts that down and decreases the chance of relapse. Skip this one. Okay, I'm going to finish up. There's a lot I have left on the handout, but I guess I'm going to finish up. I want to talk about the uselessness of detox, okay? I have never once had a patient not ask this question when I started them on methadone, buprenorphine, or Vivitrol. Not once. How long do I got to take this for? And usually by that time I'm kind of irritated. I'll say, well, only until you want to use again. And that usually kind of derails the patient-physician relationship for a while. So let me show you one study. This was done in Europe. They took 101 patients who were pregnant and opiate addicts, and they got about 40% to successfully detox. The rest kept using. Of the 40 who detoxed, nobody lost their baby, nobody had a seizure, nothing went wrong, and this was the study that the authors said proved that you can detox a pregnant patient without using medication. But, next slide. At time of delivery, they found one patient who had a negative drug screen. 1% success rate. That's the natural history of untreated addiction. You're going to be an addict, you're going to use. Okay. This is a study from Europe. They took 40 addicts, 40 heroin addicts injecting, started them all on buprenorphine. 20 stayed on buprenorphine for a year and got counseling. 20 were allowed to do what all your patients want to do. They were allowed to detox off in a couple weeks, and they didn't have to do anything. Then they looked a year later. The ones on top were the ones who kept on the medication. 75% were abstinent, and no one was dead. The bottom line, next slide, are the patients who detoxed off the medication. Nobody was abstinent, and 20% were dead. Detox just by itself does not work. Next. Okay, I'm going to skip this, and I'm just going to finish up a couple minutes with talking about the Michigan Health Professional Recovery Program, because there are 3 programs that are specialized in the country dealing with pilots, doctors, pharmacists, nurses, and lawyers, okay? And they all have incredible success rates. Their success rates are 85%. And because of this, people always wonder, how do they do it and how can we do it for everybody else? The problem with these programs is that they involve forced participation, coercion. If you don't engage in these programs, you lose your pilot's license, you lose your medical license, whatever, your lawyer's license, and you have to engage in the program, and they monitor you for 3 to 5 years, and they are on you every day. I was in this program in 1999. I'm a recovering alcoholic, and for 3 years I had to call in every day, and that way I had this negative reinforcement, this knowing that I was going to be punished or I had to go back to treatment if I did not, remain abstinent. And our Michigan program has an 85% success rate. Now, if you talk to people, they'll say, well, this doesn't matter because doctors have more to lose. Baloney. Who has more to lose than a mom who is going to lose custody of her child and all her future children? Okay? That's the situation I deal with if our patients don't stay clean in our methadone clinic. They'll say, doctors are smarter than other people. I've been teaching medical school since 1990. That smarter part, not true. Okay? I won't expand on that. Let me just reassure you, it's not true. Okay? And they'll say, well, doctors have the money. We not only have doctors, we have nurses and pharmacists, and we have a lot of people who are broke, homeless, living in shelters, and they still participate in our program, and they still do well. And then finally, they'll say, well, doctors are special people, and I'll say, yes, you're right, because we're in a safety-sensitive profession, and we are required to do this, and if you were required to do it, you would have the same success rate. You wouldn't have a 40% success rate. You would have an 80 to 90% success rate. Now, this has been duplicated in other parts of the country. There are 2 programs called the HOPE program in Hawaii and the SAC program in Washington State. SAC stands for Swift and Certain, which I would be nervous if I was on probation if I had a program with that name. And guess what their success rates are? 85%. They're based on the same principles that we have here, okay? So basically, you will go out and you will be talking to clients and you will be reading stuff and you will be talking to other people involved in primarily abstinence-based programs, and they will tell you that medication-assisted therapy is a sham, it doesn't work, the long-term success rates are terrible, and we should not use them. But these programs work, okay? Now, there's one problem with it. Just like my blood pressure pill, if I stop taking my blood pressure pill, it stops working. What a surprise, right? So people will say, well, you're just treating one addiction for another. And if you come off your methadone, you're going to relapse, okay? All right, but I've been going to AA meetings for almost 17 years now. Sometimes I run into this guy down here, and I always say that I don't know him. It's better that way. But when I go to AA meetings, I have no doubt that if I stop going to my AA meetings, I'll relapse. There's really no doubt in my mind. You can ask Dr. Minestrina the same thing if he thinks he can stop going to meetings. It's the same policy. This is a chronic, incurable, but treatable disease, and if we stop our treatment, we would expect nothing but relapse. Now, can you bounce to the very, let's see, keep going. Keep going. Okay, so is there anybody here who is not depressed after these talks? Okay. Usually after I give one of these, I just have to go lay down. This is what happened to 3 of our counselors' cars at the methadone clinic I worked at over on Jefferson Avenue in 1 year. So, next slide. This was written by Tom McClellan. Dr. Minestrina mentioned him already. And he was the one who, back in 2000, looked at addiction and compared it to all the other major medical illnesses. And here's what he found. He gave next slide. He gave a success rate of 40%. I've been talking about 40 to 60% all during this talk. 40% success rate for addiction treatment at 1 year. And there's a lot of reasons, psychosocial, financial, legally, but a lot of people say, well, if only 40% are going to stay clean, this is a hopeless disease to treat. So he looked at the rest of them. Next slide. He found that only 60% of diabetics, 40% of asthmatics, 40% of hypertensives were successful. And that fits right in with addiction, 40 to 60%. Next slide. Next. So if you were to stop taking your insulin and you were my patient and you went into a coma and went in the ICU, I would come and see you and say, listen, you idiot, you almost died. Here's your prescription for insulin, come see me in a week. But if you stopped your methadone, your buprenorphine, your 12-step meetings and relapsed and went into the ICU, I would come see you and say, next, you're an addict, you're hopeless, you're fired. And we all do that. I have done this because it's very frustrating because once someone relapses or before they become abstinent, they are not that much fun to work with. It can be very, very challenging. I'll just say that. So addiction should be listed with all these other chronic medical conditions and has the same success rate. It is not curable, but is treatable. Next. And this again is Olive, our pet therapy dog, and this is my wife Kathy. We have a practice out in Ann Arbor. And last slide. If anybody wants a copy of these slides, we had to skip a portion of it. Just send a message to me at that email address, and I will send you a Dropbox link. So thank you.